It's a Northwest Lifestyle Weekend on Como News. Here's Tom Hutler and Shannon O'Kelly with more IRG Health Talk.
All right, our next guest is Dr. Olav Jaren, neurologist from Overlake Neuroscience Institute. The topic, Myasthenia Gravis. I have no idea what that is.
Well, yeah, we're going to find out. It's a complex topic, and these neurologists out there, they are specialists in investigating neurological problems, almost detectives of your neurological system.
Let's hear from Dr. Jaren and Shannon O'Kelly.
Dr. Jaren, welcome to Health Talk. How are you?
I'm fine, thanks.
Well, thanks for joining us. We're going to talk about myasthenia gravis today. Big topic, big word. But before we get into that, I always like to kind of find out about your practice, how you got interested. You're a neurologist.
That's right.
At Overlake, but that's a specialty. And how do you get involved in neurology?
Right. Well, we think of neurology as a specialty of medicine, where we handle the health care, basically the medicine care of the brain, the spinal cord, and the nerves. You get into this by going to medical school and then choosing this path and doing some extra training and then going into practice afterwards.
Why this path for you? What was the interest, and how did you get interested in neurology? Because I got to tell you, you couldn't have picked a more challenging area of medicine. You're talking about brain, nerves, the nervous system, all these complex diseases. You're like this detective of the nervous system. That's a challenge.
Yeah, those are good words to use, and I think a lot of us become interested in this because it's challenging. We like thinking about this part of the body. Surely all fields of medicine are challenging, but this one is special because it's a little bit harder to understand. Everyone likes to know more about how the brain and the nerves work, but they we need people to help out and take care of the times when those parts of the body become ill.
Yeah, my mom was kind of a neurologist because she used to ask me all the time, "What are you thinking, Shannon? What's your brain doing?" Right?
That's right. Yeah, absolutely.
What is your brain doing? What are your nerves doing?
And I think neurologists, they like to think of themselves as detectives. It is a lot of detective work. Surely any of my patients would recognize that that's the way we talk about it too.
Yeah, it's very interesting and complex. Tell us about your training. I mean, you do 4 years of medical school. Tell us about your residency, internship, and how does that pathway work?
Well, after medical school, we all do about 1 year of internship, which is mostly medicine, and that's a lot of hospital work, a lot of general medicine kinds of things. And then years 2, 3, and 4 of neurology are neurology training, where we learn about stroke, Parkinson's disease, epilepsy, MS, and many other illnesses that affect the nervous system. After residency, most neurologists do some postgraduate training to learn some specialty skills, maybe about epilepsy or MS or things like that.
Did you do any postgraduate training? Do you have a specialty in your practice?
My postgraduate training was mainly research and a little bit of clinic with neuromuscular diseases.
Okay, so are we ready for the topic? We're going to talk about myasthenia gravis.
Sure. Yeah.
And first of all, I think we need to spell it. No, I'm just kidding. You go ahead. What is it? Let's talk about what is it.
Well, myasthenia gravis is a neuromuscular condition. It's a condition where the immune system interferes with the body's ability to turn muscles on. It is a painless weakness that often results in symptoms of fatigue, droopiness of the eyelids, difficulty swallowing, or neck weakness.
Is it fair to say that it predominantly affects the facial muscles? I mean, I've read often that people see the eyelids, the droopiness is the first, and that word is ptosis or
ptosis.
Ptosis,
right.
Ptosis,
droopiness of the eyelids. Yeah.
See, I paid attention in neuroscience when I was in PT school.
Yes, actually, what's special about myasthenia gravis is, unlike many other conditions, well, it being autoimmune is one thing, but the other thing is that it really likes to affect tiny muscles. So muscles of eye movement or muscles of eyelid opening, and not many other conditions do that.
It's a weakness. You're not gonna. It's not a fasciculation or a twitchiness. It's just a weakness. It's droopiness.
That's right. And actually, another thing that's interesting about it is that the weakness may be more prominent towards the end of the day.
So as you get tired, it's more pronounced.
That's right.
The weakness. And who seems to get this, because it's a fairly rare condition. But I think I read there's like 200,000 people diagnosed in the United States annually.
Yeah, that sounds about right. I think it's a relatively rare condition. Many neurological conditions are relatively rare. When you add them up, they're not so rare. But this can affect anybody. It can affect kids, adults, people of all ages. Autoimmune conditions, they don't really have a pattern. They can pick on anybody.
Is there a genetic component, generally speaking, or could there be?
Well, generally speaking, most cases of myasthenia are not genetic. Probably a very small subset.
More with Dr. Olav Jaren and Shannon O'Kelly right after this time out on Como.
It's a Northwest lifestyle weekend on Como News. This is IRG's Health Talk. Back to Tom Hutler and Shannon O'Kelly.
We continue our conversation on Myasthenia Gravis with Dr. Olav Jaren and Shannon O'Kelly.
Dr. Jaren, again, thank you for joining us. You're a neurologist, Over Lake Medical Center. We're talking about Myasthenia Gravis. You're doing a great job. It's a big topic. It's a complex condition. Let's just summarize and review. It's a condition, autoimmune condition. It affects small muscles, mostly in the face. You might notice a drooping. But the pathology, is the body kind of attacking the nerves that are sending signals to these muscles?
Sure. In this condition, generally, the body's immune system makes an immune response, and mostly in the form of antibodies, which actually go in and block the signal from the nerves to the muscles. So all muscles are affected by this, but the muscles that show up to patients are usually smaller muscles of the face, the neck, and sometimes the shoulders and hips and things like that.
Not to get too complex here, but when you say block, so just so our listeners understand, is there's a signal that's, we call it the synaptic cleft, basically?
Yes, synaptic junction.
And that's where the blockage takes place, so that is not connecting to the nerve, not connecting to the muscle.
Correct. What's interesting is this condition is very specifically blockades one signal from the nerves to the muscle, one chemical signal, and prevents it from being transmitted.
Again, I mean, I'm talking complex here. I'm talking about your neurological system in your body is fascinating, but it's complex. What can we do to treat it, and what is the kind of the prognosis for most people? I mean, it comes and goes, maybe, it waxes and wanes.
Yes, this condition can have exacerbations that are very bad, and it could be relatively silent. And it's hard to predict when it will be active or not active. This condition can be managed by physical therapy, medications, sometimes medicines that help to increase the signal flow through the synaptic junction.
Is there a certain marker as a neurologist when you do a physical and history with a patient and you're going, oh, I suspect this is myasthenia gravis? I mean, do you draw blood? Is there anything you're looking for? Is there a definitive diagnostic test?
Well, I would say as much as there can be, there is. The history and physical are paramount, as they are for any medical condition. Often, patients with this condition have an abnormality in their blood where they have antibodies to one of the chemical signals within the junction, the acetylcholine receptor is called. Sometimes they'll have some patterns of abnormality with electrophysiologic testing that are specific to this condition.
And so how do you treat it then? I mean, what do you do?
Well, depending on the severity, a person might have a relatively light or heavy-duty immune suppression medication. They might also use a medicine called mestinon or pyridostigmine that increases the amount of the chemical in the junction to overcome the blockade.
Interesting. So what's going on in the world of medicine right now is a lot of biologics. I mean, it seems like biologics are real, particularly with these autoimmune diseases. Are you seeing any kind of research on the horizon?
Sure. Over the years, there has been quite a bit of interest in managing autoimmune conditions with treatments of that nature. With myasthenia, specific biologics like you see in psoriasis or in rheumatoid arthritis, we don't exactly use. We use some of the old-fashioned ones, prednisone, Cellcept, sometimes other medications that are special, like rituximab in rare cases.
Yeah, as we wrap up, I mean, you've done a great job. Is there any indication what triggers your immune system to attack the body as we wrap up?
Well, we think that that's speculative, so I would say probably, but we haven't figured it out exactly.
Well, Dr. Jaren, again, thank you for your time. Great information. Thank you for joining us.
Oh, you bet. Anytime. Thanks for having me.
All right, you've been listening to Dr. Olav Jaren talking about myasthenia gravis. Pretty interesting topic. Our immune system has a lot going on.
Pretty fascinating system. Your immune system is there to protect you, but when it turns on you, all these autoimmune diseases that we see can be problematic.
We're back with our final segment right after this time out on Como.